Hmm. Now just for a little bit of tweaking and that's it. Whoa, didn't see you guys there. Welcome to my virtual clinic. Today we'll go through a small session learning how do we. Is there someone at the door? Please come in. Excuse me, sir. The receptionist sent me in. Are you busy? Of course not. I was expecting your arrival. Mr. Zero, am I right? Yes, that would be correct. Well, Mr. Zero, the reports of all your investigations have arrived. So what is it, sir? Anything serious? Don't worry, I have made a presentation concerning your case. Just have a look. You'll understand everything in due time. Okay, sir. Where should I be looking at? The black screen behind you. I'll look it up with my laptop. So now let's jump right to our case. So the surgery case of ours is that of a 63-year-old man complains of a 6-month history of difficulty voiding and feeling as though he cannot empty his bladder completely. After voiding, he often feels as though he needs to urinate again. He denies a urethral discharge. He has a mild hypertension and takes hydrochlorothiazide for it. His only other medication is ampicillin prescribed for 2 urinary tract infections during the past year. An examination, his blood pressure is 130 by 84 mmHg and his pulse rate is 80 beats per minute. He is afebrile. Findings from the examination, the heart and the lung are normal and the abdomen clearly reveals pneumonia. So now let's start deciphering our case. Symptomatology. We have been given in the history of the patient certain vague sentences which include the symptoms. Now let's clearly define them. Difficulty in voiding would mean hesitancy or is there is a poor urine flow. Feeling as though he cannot empty his bladder completely, there is a sensation of poor bladder emptying. Often feels as though he needs to urinate again, indicates either there is the urgency or probably the patient's frequency of going to the bathroom has increased. And he doesn't have a fever, which was stated to us. So now how do we approach the diagnosis of our patient? Based on the symptomatology of the case provided to us, the problem is localized or seems to be localized in the lower urinary tract, comprising of the bladder, prostate, and of course the urethra. But the consequences of systemic illnesses of the following structures should always be investigated because we often tend to go away from this. So systemic examination also forms a very important part of our investigation. Abdominal examination. Why do we need to do this? You ask. Chronic retention of urine sometimes appears in the form of a palpable mass, that is, the bladder, because of the presence of the residual volume of urine in the bladder. Rectal examination is one of the specific and sensitive tests done for prostatic pathologies, let it be BPH or be it carcinoma prostate. Based on the consistency of the prostate and its enlargement, we can get a suspicion of malignancy or that of benign enlargement. We often tend to forget the systemic examinations while doing such specific lower urinary tract symptom investigation. But neurological lesions such as Alzheimer's, Parkinson's disease may cause a neurogenic bladder, which may again appear in the same form as that of the lower urinary tract symptoms and hence may confuse us in our diagnosis. Serum prostate specific antigen. Although it lacks specificity in defining the prostatic pathologies, it is a highly sensitive marker and is of a very high value in prostate cancer in early identification as well as later prognosis. Blood test. Particularly the serum creatinine is very important as it helps in determining the kidney function of both of our kidneys. Its raised value is an indicator of impaired renal function. Urine analysis. To check for the presence of glucose, blood, bacteria, or the cells in the urine. This helps in identifying the probable UTIs or the malignancies, particularly that of the carcinoma in situ. Euroflowgram and urodynamic studies. These investigations have a significant role in identifying the bladder outlet obstruction and the detrusor muscle dysfunction. In a normal urogram, we have two curves, a red curve below indicating the volume of the urine being emptied, and a blue curve above indicating the flow rate of the urine. In a normal urogram, as the act of micturition commences, the volume goes on depleting and the flow rate first increases rapidly and then decreases at the same pace. Normally, the flow rate is greater than 15 ml per second, which you can easily see in the top right corner of the first graph. In the second image from the top, the flow rate seems to be very less, approximately 5 ml per second. This seems to be suggestive of bladder outlet obstruction, urethral stricture, or weak detrusor muscle action. In third graph, along with the low flow rates, we can also see a pressure volume curve in which we can see there is a significant rise in pressure above 80 centimeter H2O. This right here is diagnostic of bladder outlet obstruction. Imaging studies, they are not routinely done. They may help in the localization as well as to define the extent of lesion, but again, they are not routinely done. Techniques through which these are done are MRI, CT, and transrectal ultrasound scanning, which is generally done for larger prostates. And upper tract imaging was done in the older times. Nowadays, it has become obsolete. So, what could be the diagnosis? Now, based upon the symptoms and investigations that we have come across, let's jot down the possible diagnosis of our given case. In a male above 60 years of age, presenting with LUTS, the clinical suspicion of BPH is very high, as nearly 50% of the individuals above this age group have the risk of possessing the disease. Carcinoma prostate, on the other hand, the suspicion of this also revolves around this age group, but a little higher, that is above 70 years of age, and hence is needed to be kept in mind while making a diagnosis. Digital rectal examination and biopsy may again help ascertain the diagnosis of carcinoma prostate. Urethral strictures. It may also show the features of LUTS, and further investigations may help bring the truth about this condition in our given case. Prostatitis. It may also appear in the form of the LUTS symptomatic complex, but the signs of inflammation and others are moreover helpful in diagnosing this condition. Detrusor instability. This idiopathic condition can be distinguished from bladder outlet obstruction in the urodynamic and UROFLOWMETRY investigations. In case of neuropathic bladder dysfunction that occurs secondary to diseases like Alzheimer's, diabetes mellitus, Tabes dorsalis, and Parkinson's disease, these should also be considered in the differential diagnosis of our given case. What are the significant findings of our case? We do have low flow rates of urine, that is less than 10 ml per second, which again seems to be suggestive of bladder outlet obstruction. The uniform prostate enlargement with a smooth convex contour on DRE, that is digital rectal examination, seems to be suggestive of benign prostatic hyperplasia. On MRI, a characteristic median lobe is visualized, which seems to be obstructing the neck of the bladder. Now, this is highly suggestive of benign prostatic hyperplasia. So, the most probable diagnosis, in my opinion, would be benign prostatic hyperplasia or BPH. So, how do we go about the treatment of this patient? In the initial treatment, we will give him the medical management in the form of the two types of drugs that are alpha-1 blockers, such as tamsulosin, silodosin, alfuzosin, which helps in relaxation of smooth muscle and help in passing of the urine, and 5-alpha reductase inhibitors, which reduce the size of the prostate. Indications for surgery are, the most important one is the failure of medical management. Others are elective prostatectomies, acute urinary retention, chronic retention with renal impairment, hemorrhage, and complications of bladder outlet obstruction. So what is the gold standard surgical treatment? That would be transurethral section of prostate, or TURP, with Verumontanum as a surgical landmark, Resectoscope is introduced in the urethra, and the prostate is broken down into chips via the monopolar or the bipolar diathermy, and along with its proper irrigant, of course, and is then these chips of prostate are evacuated with the LS evacuator. The procedures are of the following time, that is the holmium laser enucleation and Millen's prostatectomy. Both are done for larger prostates, and the transvesical prostatectomy is very rarely done these days. The complications being the most common one is the retrograde ejaculation. Others are majorly due to surgical intervention, such as incontinence, impotence, urethral stricture, lateral neck contracture, sepsis, water intoxication. And that would be all. Thank you.